Welcome back. To continue our discussion on pelvic floor dysfunction, joining me again is Dr. Spiros Marinas. He is the Chief of Gynecology and Urogynecology at OU Physicians in Tulsa at the Schusterman Clinic. Let's jump in. In our first segment, you did an excellent job clarifying for us this whole concept of pelvic floor dysfunction and what it involves, and kind of I asked how are we prone to this, because it's such a great statistical increase the older you get of having some of these problems. I do want to ask you, as I mentioned before the break, about exercise. If women really exercise on a routine basis, which is good for health in general, is it helpful for these types of dysfunctions to kind of minimize the prolapse or delay it or anything such as that?
It is a very funny question, because the muscles that have to be exercised in order to prevent or stabilize or delay the progress of the prolapse, there are muscles that 4 out of 10 women, they don't even know how they feel when they contract, when they are really exercising.
Okay.
This is when you need the help of specialized physical therapists or pelvic floor rehabilitation specialists who teach these women how to identify the muscles, how to exercise them, and how to maximize the benefit of the pelvic floor muscles rehabilitation in the not only the prolapse, but in the whole spectrum of the pelvic floor pathology.
Okay.
Yes, indeed, but they have to know, and they're very, very specific muscles.
Okay, in our next segment, we will have a physical therapist that works with you joining us to actually discuss that. So tell people to look forward to that.
Yep.
So, okay, we have to know specifically what to exercise, and most
Correct.
women don't know what to exercise.
Correct.
So as a result, when we're thinking we're doing general exercising, whether it's jogging or swimming or biking, that's not hitting these pelvic floor muscles that we need to do.
On the contrary, you may just increase your intra-abdominal pressures and your pelvic pressures in such a degree that you may compound the problem. You may make it even worse.
Okay.
So if you don't know how to use your pelvic floor muscles, just exercising is going to keep you in a very good cardiovascular conditioning, but it's not necessarily going to do any benefit on your prolapse, incontinence, or other problems in your pelvic floor.
Okay. Wow. Now, let's talk a little bit about then the prolapse. You mentioned earlier about the fact that it could be the bladder,
the rectum, the uterus itself,
everything just...
Or the vagina after hysterectomy can
just
fall.
falls.
Yeah. It's like a hernia. Just imagine you have a hernia in your belly. This is a hernia in your pelvic floor. There is a weakness in the pelvic floor. There is a weakness of connective tissue and of muscles. And that's why the organs that are normally supported by this, means connective tissue and muscles, start becoming more relaxed and progressively dropping just by the mere effect of gravity in your everyday activities.
Okay.
And you may have no clue that this is happening, because you may not be able to see it or to touch it, but women describe it as, I have a pressure, I have a feeling that I'm sitting on a ball, I have a problem to initiate my voiding, or I have a problem to continue voiding, or I feel that I do not empty my bladder, or I cannot finish having number 2, or I have to use, some women have to use their hands to splint in order to finish number 1 or number 2.
Okay.
Or it might go in the way when they have sexual intercourse. So this could be the symptoms of the prolapse. Usually prolapse does not cause pain, so women are not going to come with painful symptomatology.
It's just noticing, like you're saying, those differences in voiding, maybe having to go to the bathroom more frequently because you just didn't empty totally before. Like you said, being more constipated, having more effort there.
Correct.
Those types of things.
Correct. And then we reach the very last point that you may just be able to see it. I mean, there are women who are just having the whole uterus and cervix prolapsing all the way out in between, you know, their legs, and they didn't know that there is help for that, and they just live with that.
And you just, all of a sudden, one day, there it is.
Not all of a sudden.
Okay, doctor, that was a frightening thing.
No.
Is it like a gradual?
It's a very gradual thing.
Okay, okay.
Very gradual.
Now, with women having, as they should, routine pap exams and things such as that, is this something that the physician should be able to pick up on early, that these are beginning to happen?
And usually the physician picks up early, simply if the woman does not complain about anything.
Right.
This is not something that is going to kill you. This is not something that is going to harm your health, with one exception, is that if you cannot empty your bladder. But if your bladder empties well and you have no symptoms that bothers you in your quality of life, the physician just points out, yes, you have a dropped bladder. But this is not something that you must correct unless you feel symptomatology or your quality of life has been compromised of that.
Okay.
That's why there are very specialized questionnaires that everybody, every general practitioner, every gynecologist can give to the patients. And then the patients, on their privacy, just from their home, they can just check the answers, and then you can score the problem and know exactly where you stand with the problem.
Okay, now let me ask you this, doctor, due to our timing. Okay, so let's say it is becoming problematic for the woman, because it sounds like nothing needs to be done until that happens. What are you going to do? I mean, do you go in and tie things back up and tighten them and reorganize? What do you do?
There are essentially three options.
Okay.
One is to do nothing interventional, but only to have a personal trainer, namely physical therapist, who specialize on that, and give the most that you can give on the pelvic floor muscle rehabilitation.
Okay.
It has been shown that in mild to moderate prolapse, you may just stabilize it, or there are few studies that you even got it to go back.
Okay.
This is not exactly my experience with what is going when you have prolapse that comes to my hands. Then you have two options, either to use pessaries, means plastic-made devices that are placed in the vagina. Woman does not feel it, but keeps the things in place.
So it's something that you put inside the vagina to lift everything up.
Exactly, exactly. And there are some women who do excellent with that. And they can stay with that, you know, forever. This is what people were doing before the advent of surgery, because we started doing surgery in the 1930s, 1940s. So now we are privileged to have amazing surgical techniques, having very low morbidity, very low mortality. So we can offer to women surgical reconstructive procedures that are usually done either vaginally or laparoscopically. Last resort could be abdominally. And you can use the patient's own tissue plus minus some extra graft tissue that is usually made from a polypropylene material, and you restore the anatomy. And with the anatomy, most of the times, you restore the function as well.
Now, with this procedure, is it where you also just do the hysterectomy and remove the uterus and
if it is
tighten
needed,
up the other organs?
Correct. Majority of the time, women who have these problems have completed fecundity, they have completed childbearing. So when they come to us, they do not need the uterus. So we know that the results of any kind of reconstructive surgery are much better when you perform a hysterectomy, or if the hysterectomy has already been done. Okay,
but if the person is still in childbearing and wants children, that's when you will try to
keep
the conservative measures. Now let me ask you in our last few seconds here, the prosthetic device that you said that can be used, once it's inserted, is this something that you have to come back for every so often to get a new one put in? Actually, or anything such as that?
There are lifetime duration. What you have to do is for initial 2 weeks, you have to come back in order to see if it is the right fit for you, being taught how to remove it, replace it, take care of that. And if you become proficient on that, you don't have to see your doctor but once every 6 to 12 months. There are women who cannot, replace it because they have rheumatoid arthritis or they have problem with their hands. So you can place this, keep it for 2 months, and every 2 months they're coming to the physician who check, clean, and replace it.
Okay, so if the woman can do it on her own, she's taking it out, cleaning it, and and then replacing that.
Correct.
Okay, well, thank you, doctor. We're out of
You're
time.
welcome.
You gave me so much information, and the viewers as well, to know what to look for, because it sounds like it's all inevitable, and to visit you when we have those problems, and maybe before, to see what's going on.
Correct.
Thank you so much.
You're very welcome.
Please stay with us. We'll be right back.